Good morning, and thank you very much indeed for joining us today for the Marie Curie Research into Practice Conference 2025. Delighted you've been able to join us. My name is Matthew Reid. I'm Chief Executive at Marie Curie, and I'm delighted to be able to open this 4 days of conference. Once again, we're delighted that it's free to all and open for all to attend for anyone who's got an interest in palliative and end-of-life care. So welcome, and thanks for joining us for what I'm sure is going to be a hugely engaging and invigorating week. But over 90 speakers across these 4 days. My thanks to all of the speakers for all your preparation and in advance for your contributions to our conference. Thank you for sharing your latest findings and, of course, your contributions in the field. We're going to be hearing from a range of professionals covering topics right across palliative care and end of life, those who are working hard to identify, to research, and to address knowledge and service gaps. The aim for us in this conference is to share that latest research and evidence with the widest audience possible, practitioners, researchers, policymakers, and anybody else with experience of and interest in palliative and end-of-life care. And we're really honoured to have such a varied and, in fact, international audience joining us this week. Research and its translation into policy and practice is one of the most powerful ways that we can achieve change in end-of-life provision at scale. And at Marie Curie, we use the findings and evidence from research to influence both our own work and, of course, to influence other people's work and policy and practice as well. We're proud to be the largest charitable funder of palliative and end-of-life care research in the UK. We want to make sure we not only fund high-quality research, as we do, but also make this evidence and evidence from this research available throughout the field and share it widely open so that everyone can have the greatest impact from what has been discovered. Our ambition, in fact, our passion at Marie Curie is a better end of life for all. We hope that you will feel inspired, intellectually and invigorated and emotionally from all that you learned this week and for all that you might be contributing to as well. We hope it will help shape your thinking, direct future research questions, and influence policy and practice to improve end of life for all. So thank you for joining us for this first session of the conference, which follows the theme of shaping tomorrow's palliative care, innovations and transformations for the future. That's our theme today. The first half of the session will explore more recent findings of public expenditure on people in the final year of life, and we're delighted to be able to share some leading research on that this morning. This will be followed by a panel discussion focusing on where change is needed and how innovative and collaborative services that link palliative care in hospitals, emergency services, out-of-hours assistance can better support people at the end of life and ease system pressures. Short break at 11:30, and then we'll close the session with the awarding of Marie Curie's 4 prestigious conference prizes. Now, though, I'm going to pass over to my colleague, Dr. Sam Royston, who's Executive Director of Policy and Research at Marie Curie, who will be chairing today's session for us. Over to you, Sam, and thank you.
Thank you, Matthew. I am so excited to be here for this morning's session, opening our research conference for the week and on such an important topic. What more important topic could there be than innovation and change in an area where it is so needed? So before we launch into our kind of first presentation and what fantastic lineup we've got this morning, a little bit of housekeeping. So there will be time for audience questions after the first presentation and during the panel discussion. So please type your question for our speakers into the chat. The chat is available by clicking the message icon in the blue panel on the right-hand side of the screen. I can't see it on my screen right now, but I'm going to believe it's there. I believe. And it is just type your questions into the text bar there. And please make sure to use the presentation chat and not the event activities chat, which is situated above this. So hopefully that all makes sense. We encourage you to use the chat to let us know where you're watching from and what has brought you to the session. We want to know. We want to find out who's watching. Please direct questions to the chat, and a member of the conference team will support. We also have a help desk booth for further queries and technical questions outside the presentation. Wow, it is all high tech here. Please do explore the wider platform after the session, which includes many conference posters, some fantastic conference posters there, and further booth resources. To navigate the platform when you're not watching a presentation, please click the compass icon at the top left-hand corner to explore. So top right-hand corner chat, left-hand corner exploration with the compass. This session and all sessions are recorded and will be available on demand on our conference platform. So without further ado, our first presentation is from Dr. Sarah Scobie, Deputy Director of Research at the Nuffield Trust, who joins us now to showcase her research on public expenditure on people in the final year of life. Sarah, a very warm welcome, and over to you.
Thank you very much, Sam. And it's really great to be here. Slightly daunting as I can see the number of participants going up at the top of my screen as we talk. So hopefully you'll all stay till the end. So I'm really looking forward to sharing this research, and I'm just going to press the share button, and hopefully in a minute some slides will pop up. Can everybody see them? Yeah,
Yes.
Perfect, thank you. I'm going to assume that's the case. So as Sam said, I'm here to present work on public expenditure on people in the last year of life in the UK, and this is a piece of work which has been done jointly with the Nuffield Trust, where I come from, and also the Health Economics Unit, which is an NHS-based health economics team. And so I'm hugely grateful to all the co-authors who you can see here on the screen, and of course to Marie Curie and Sam and Emma Morn in particular, who've supported this work. All right, so just as a bit of context, particularly at a time when health systems in the UK and indeed across the world are thinking about how they can best meet the challenges for healthcare in the future, it's worth bearing in mind that in terms of end-of-life care, one of the key population changes in the UK is the expected increase in the number of people who are going to die each year, and this is as a result of population change and aging. But basically, for the UK, it means around a 13% increase in expenditure in the number of people who are going to die in the next 10 years. So that's about an extra 90,000 people. So I think that's worth bearing in mind in terms of why this is such an important issue for us to understand. So in terms of the focus of this research, so we know that around, at the moment, 650,000 adults die each year in the UK, and the quality of their life is greatly impacted by the care and support that they receive from publicly funded services. And we also know from particularly from Marie Curie's work that the final year of life can often be a time of financial hardship for many people, both to meet additional expenses and because of loss of income. So it's particularly important that we understand where public resources are going, and what we found at the beginning of this project, and which was one of the reasons why I was instigated by Marie Curie, is that it's actually difficult to get hold of that evidence quickly. There's very little routine evidence on public expenditure, and this leaves policymakers with a gap in the decision making around funding for end-of-life care, and small pockets of funding are kind of seen in isolation of the bigger picture. So the aim of this project is to address that gap and to estimate how much the UK spends, and this covers healthcare, social care, and also social security, so benefits, and we'll come on to all of those areas shortly. So just in terms of the nuts and bolts of the project, so it was a rapid analysis done to a short time frame, and very much relying on either evidence and information, statistics that have been published, research literature, or also information held by organisations, and in the full report it details all of the sources that we used. We focused the analysis on the year 2022 to manage the best availability of data, with also coming up with findings that were as timely as possible. And the work focuses on adults only, because of quite different sources of data relevant for children, and not really being able to cover that within the scope of the project. So as I say, it covers the UK, and the full report has data for each individual nation in the UK, as well as the overall picture that I'll be talking about today. It's quite a number of things that we weren't unfortunately able to do. So we couldn't look at effectiveness of different services. We didn't cover carer expenditure, so self-funded care, and we didn't cover mental health. I'll talk a bit more about data gaps towards the end, but just to say at this point, there were a lot of data gaps, and that influenced the assumptions that we were able to make. So just in terms of what we did then, so we identified the components that we were that we thought were important in terms of end-of-life care, pulled together all of the information that we could, and then built estimates from that. So using the data that we had, often combining multiple sources of data to come up with the best estimate that we could, and we included some sensitivity analysis as well to take account of that. And one thing I really want to do is to thank all of the stakeholders that we spoke to during the course of the project. So we engaged with around 50 people. We held individual meetings, we communicated with people by email, and we held a workshop as well at the beginning of December to bring together experts and stakeholders with a range of different skills and expertise. So I'm going to start off with the findings then for the UK, and talk about each of the different components. So our headline is that we estimate that it's around 22 billion spent of public expenditure related to people in the last year of life, which works out at around £34,000 per person. And as I said, these UK estimates are built from the estimates for each UK country, and then aggregated together. And so in terms of how this expenditure is distributed, over half of it goes on healthcare, almost 12 billion, and then the rest split between social care, just under 5 billion, and social security payments, 5.5 billion. But that's the overall split across the three sectors that we looked at. And I'll talk through now in a bit more detail each of those sectors. So starting off with healthcare, this chart shows the range of expenditure across different types of services. And I think the very striking thing about it is that the two central sections on hospital care, unplanned care, and planned care in hospital are the biggest part. So 4/5 of healthcare expenditure that we were able to identify is on hospital care. And in fact, over half is on unplanned care in hospital. So that's A&E visits, but the bigger part is unplanned hospital admissions. And that reflects the fact that these are very common for people at the end of life, and people are often in hospital for quite a long time. And so this is a really big area of spend. In terms of services out of hospital, so for primary care, we looked at general practice contacts, and we also looked at prescribing. We looked at ambulance services and NHS 111, or the equivalent in Scotland, NHS 24, community contacts, and also hospice care. And I'll say a little bit more about hospice care in a minute. But just to say that, as you can kind of see from the chart, relatively the amount that goes on community services is very much smaller. So we spend 5 times more, for example, on hospital inpatients alone than we do on primary care, healthcare, and hospice care. And just to try and put this in context, this is data that just actually relates to England, and the proportion, and what this looks at is the proportion of all healthcare spend which is related to people in the final year of life. So for ambulance services and acute healthcare services, it's around 10%, a much smaller percent for community services. But it's actually surprisingly difficult to make a direct comparison with all healthcare spend, because the overall numbers for that include all sorts of other things that wouldn't have been included in our individual estimates. And as I say, I mentioned hospice expenditure. So for this, we were very grateful to Hospice UK for providing us with this information. And this relates to expenditure by independent hospices. And within this, and within the data that we used in the report, we only used expenditure on service provision. So clearly hospices spend money on their retail and their other activities, their charitable fundraising activities. But if you just look at the service spend, around 44% of it is publicly funded, either from healthcare commissioners, ICBs in England, for example, or from government grants. And so 56% is funded from hospices' charitable activities. So I'm going to move on now to social care. It was quite challenging finding data on social care, and we did rely on some data from a much earlier study that Nuffield did about well over 10 years ago, to estimate the proportion of social care expenditure which relates to people at the end of life. There is a new, in England anyway, social care data set which may help with this in the future. But what we found is that for the services funded through local authorities, residential and nursing care accounts for the largest part, and in fact it's the largest part in terms of social care spending overall. Then there's also home care and other services of things like equipment grants and that kind of thing. And we also, within the social care spend, included funding on continuing healthcare. So these are packages of care which people can receive who have complex health needs, and there is a particular route to accessing this which is accessible to some people at the end of life. So it's quite a substantial aspect of funding. But just to remind you, this is only publicly funded social care, and so it doesn't include self-funded social care, so people who are paying directly. And so we know that just looking at residential care, for example, around a third of residential care is funded directly by families and individuals, and not from the public purse. So finally, I'm going to talk a little bit about social security. So the biggest chunk of social security spending is the state pension, with a small additional amount on pension credit, but nearly 90% of social security spending is on the state pension, with much smaller proportions of spending on benefits that people can receive at working age, and so in particular benefits that there are eligibility criteria for, much smaller aspects of spend, in particular those that are also means tested. And so I think this just gives a really clear picture of where spending is going at the moment in terms of benefits. So just to kind of put that all together, so you can see the three sectors. I think one of the things that I find still really striking about this is that even when you include social care and social security, unplanned care in hospital is still where the lion's share of funding is going. There is a full report that has all the detail. We've also written a blog about some of the challenges around the data collection. So I'm sure if you Google those, you'll be able to find them, but the details are there as well. So just lastly, and to move us into the discussion, it'd be good to just talk a little bit about what we think the implications are from this, and starting off with the implications for policy. I think one of the very striking things is that in some ways end-of-life care is such a neglected area. So the fact there's very little routine data for this important cohort of people. In our work, we've been as transparent as we can be, but there's definitely areas where we're sure that these estimates could be improved with better data. And I think that speaks to the challenges around the lack of data, speaks to the lack of focus of this as a policy area. And I think this is really interesting as someone who works in health policy. When you look at new plans, you know, the urgent care plan, the elective care plan, these things are almost completely blind to people at the end of life. There's almost no mention of them, and I think that's a really important point that we need to try and change. And I think similarly, the public debate around funding for end-of-life care is very much about hospices, which hospices clearly play a really vital role. But actually, I think this data shows that within the context of all of the expenditure, even if it was all publicly funded, it would still be only a small part. So I guess my second point then is going back to the predominance of hospital care and hospital fund of expenditure that we saw. And I think there are some real challenges here for policymakers, because across the UK and more generally, there have been efforts to shift care out of hospital for some time. And so I think we need to really think, well, what's going to be different this time with proposals coming forward in England, for example, for the 10-year plan. And I think that it's really important to really understand what is happening in hospital, why are people in hospital, and think about what needs to change to make it different in the future. And I think the other aspect which we didn't have a chance to get into in our research is to really think about inequalities in the end-of-life care pathway. We know that people from more deprived areas are more likely to attend A&E at the end of life, more likely to be admitted to hospital, and more likely to die in hospital. Understanding why that is, what services would be needed, how services would need to be differently accessed and differently organised to provide better access across different communities is going to be, I think, a really important area for understanding better, and links, in fact, very much to the other aspects of the study, so social care and social security. So people's resources to stay at home at the end of life, whether they can access the care and support they need, are very variable between different communities and people with different resources. So then, in terms of improving estimates for the future and where there are particular data gaps, so there are some areas, so community services and social care, where it was pretty difficult to find data that we felt was comprehensive and reliable. So those are two areas that we need to improve, and it would be great to see much better linkage of data from health, from social care, from social security, with mortality data, so that we can really accurately identify people at the end of life and get a much more granular understanding of what the care pathways are that people are following. We also had questions in the analysis we did about the cost data. So by and large, unit cost data, so the cost per admission, cost per outpatient appointment, is for all people, and the question to which people at the end of life have different needs, and the costs for their care specifically are different, is something that we definitely would have liked more time to explore. As I said at the beginning, the report covers estimates across the whole of the UK, but it was much easier to find data for some countries than other. So in particular, there's more research data for England than there is from the other countries. So in some cases, we had to estimate using data from one country or two other countries to make our estimates, and that made it difficult to know how reliable the results were. And as I say, improving estimates in the future as well. I think understanding variation and inequalities will be really key to that. So just to wrap up, so the headline that we found was 22 billion spent, so that's around 34,000 per person, per adult who died in the UK. Over half of that is spent on healthcare, and hospital costs account for 80% of all of those healthcare costs, so particularly emergency care. So this gives us a really good estimate of spending that we can start to then use, but within the scope of what we did, there are lots of things that we didn't answer, and I hope it'd be great to hear people's thoughts on these as we go through the discussion today. So is this the right amount? Are we spending it in the best way? And are people getting what they need? So I will stop there and hand back to you, Sam.
Thank you so much, Sarah, and what a fantastic study. It's been a delight, incidentally, working with you and the team at Nuffield Trust and Health Economics Unit on it. I couldn't believe, really, that we didn't already know how much we spent on people at the end of life and how that broke down. And I mean, I am always struck by since we published the findings by the fact that we spend 5 times as much on people in the final year of life in hospitals than on GPs, district nursing and hospices combined. It's just astonishing. Was there anything, Sarah, that kind of surprised you when you were doing the study? Anything that really stuck out to you as I wasn't expecting that?
Yeah, I mean, I think the size of the emergency hospital spend relative to other areas was, even though we were expecting it to be high, I think that really struck us. And I think the other thing is the gaps in the data. So particularly social care. As I say, there is now a new data set for England on adult social care, but we really struggled to find good data for social care, and it's just such an important component for helping people to have a good quality of life at the end of life. So really struck by that as well.
That's really interesting. You talk a lot about the data gaps. Is there anything that you'd like to see in particular done to address the gaps in the data which do exist?
Well, I think that one of the things would be, as I say, I mean, social care, community care, but also more publication of service data related to people at the end of life, which you'd need to get from linking data. So there really isn't very much that's routinely available. So in England, OHID publish I think the number of people who've had more than 3 emergency admissions, but that's kind of almost the only routinely published data specifically on people at the end of life. So using linked data and then generating routinely published data. And I guess the other big thing would be thinking about comparable data across the UK. So that's often very difficult, even actually places of death being reported consistently in the 4 UK countries is something that's surprisingly not the case.
That's so interesting, isn't it? Because there is so much that we can learn between the 4 UK nations, from different approaches to different ways of approaching health and social care provision. But if the data doesn't align, then it's really different to explore that, and maybe that's an area which can think about kind of focus on for the future. That's really interesting, and in fact, we'll see examples of models of practice from Wales shortly, and actually looking at those kind of different approaches helps us to understand what can be done differently. How can we share learning? But yeah, we clearly need to do more around aligning data there. Can I ask specifically on that kind of question of social care provision, why is there such a challenge around getting social care data in particular? Why are we so bad at doing that?
Well, I think the social care sector is, in terms of provision, is very fragmented. So you've got a lot of often quite small providers working locally, and there hasn't been a data collection which captures data about what services are actually provided. And indeed, the one that's being proposed in England is only local authority funded care that is getting underway. So that's still going to be a gap. So I think that's part of it. I think it's often also the case in terms of the provision of social care that people who are providing those services, they will have huge expertise working in people at the end of life, but the recognition, the recording that people at the end of life, the information about their healthcare needs won't be held by those social care organisations. So I think even if you captured all of that social care provision, unless you then linked it to healthcare data, I think there would still be a gap in terms of what we know about social care provision for people at the end of life.
Fantastic. Thank you so much, Sarah, for that introduction. What a great way to kind of set the scene on the need for innovation and transformation in palliative care provision, to talk about how we, as a whole society, spend our public money on people in the final year of life and where that money is going. So what a fantastic introduction. Thank you. Thank you, Sarah. Now we will, I am seeing people introducing themselves in the chat from all over the world, which is wonderful, fantastic. Thank you so much, and lovely to see so many people joining us this morning. We will move on now onto a panel discussion on this topic, building on Sarah's presentation. A reminder, as the panel gets underway, do put questions in the chat. I've seen a couple of questions for Sarah already, which we'll pick up as part of the panel discussion in a little while. But do continue to put questions in the chat for all of our guests this morning, and we will start to move on to onto the session. So. For the panel discussion, I'm joined by Dr. Sarah Scobie, who will be remaining with us. Thank you, Sarah. We're also joined by Professor Patrick Vernon, OBE, who is the chair of the Birmingham and Solihull NHS Integrated Care Board. Thank you so much for joining us, Patrick. We're joined by Ed O'Brien, Professional Development Lead for Frailty and End-of-Life Care at the Welsh Ambulance Service Trust, and Dr. Sarah Holmes, Medical Director at Marie Curie, and also the executive sponsor of the REACT programme, which we will hear a little more about as well. Thank you so much all for joining me today. I'll start with an opening question. And then we will, as I say, start to take some questions from the audience. But as we look ahead to the next decade, there are going to be at least 3 major shifts that are shaping the future of health and care, irrespective of what that future more broadly looks like. We are moving from provision in hospital to home, from analog to digital, and from treatment to prevention. That's what at least the UK government is aspiring to, and I think that's true across the UK nations, and indeed in many places. I think also very true worldwide. All 3 shifts will have a significant impact on the delivery of end-of-life care and the models of service which are needed. And will have particularly consequences for, we know there are existing inequalities, profound inequalities in the delivery of end-of-life care. These shifts, they both provide opportunities to engage with and address those inequities, but also risks and challenges to how they could be further entrenched and deepened as well. So, in our panel discussion today, Shaping Tomorrow's Palliative Care, Innovations and Transformations for the Future, we'll explore the biggest system pressures, discuss innovative approaches that are making a difference, and look ahead to the future. And we'll have all of that sorted in the next hour, don't worry. So, with this in mind, I'll just throw this open to the panel to start with. Could I ask each of the panelists to give a brief introduction to yourselves and share your perspective on what you see as the biggest system pressures for palliative and end-of-life care. So perhaps I can go over to you, Patrick, and ask for your perspective on this. Not this pretty huge question.
Sure. So, hi everyone in the UK and around the world. So I'm Patrick Vernon. I'm the chair of Birmingham and Solihull Interim Care Board. We basically commission healthcare for the population of the city of Birmingham, second capital city in the UK, along with Solihull. We have a population of about £1.3 million, and we're probably one of the biggest and sort of complex health systems in the country as part of the 42 ICBs doing something similar. From my perspective, as you said, Sam, you mentioned about the free shifts. To be quite honest, our ICB have already been doing that work when we set up over 2.5 years ago, to be quite honest. We've started the process, how we are working closely with all our NHS providers, hospitals, community trusts, mental health trusts, working with primary care, working with some of our specialist hospitals, such as the Children's and the Royal Orthopaedic, and our 2 local authorities, to try and have a system approach around integration, collaboration as well. And this feeds into the work around palliative care. As you know, the NHS is under severe financial crisis. You probably see all the reports every day, and even more reports of what's going to happen in the future. The government's made it very clear to us that all systems need to balance their books and live within their means. And to be fair, as ICB, we've been doing that for the last few years. We've balanced our books for the last couple of years, and touch wood, we're hoping to do it again in this financial year. I mean, yesterday we had our board seminar, look at some of these big challenges. What we're going to do, how we're going to prioritise, how we're going to do things differently, how we're going to, the short-term pressures around electives, emergency care, the front door of hospitals, engaging more with primary care, how we look at better working with local government, are the things we were exploring yesterday, and how we plan that differently as well. I think Sarah's report really chimed with what were some of the challenges that we're facing and some of the big issues we're facing in Solihull. We have 4 hospices, and as you know, Sam, I had the pleasure last year of visiting the Marie Curie hospice in Solihull. All our hospices are under financial challenge, as it's, and all the money that we're spending, there's a conversation about proper funding for hospice services. I'm sure something that I'm sure that's going to come out throughout the days of the conference. But as Sarah's report alluded to, and it fits into our model and thinking, that all our money is in acute. 47% of people that die in hospitals in Birmingham Solihull, which is above the national average, and all our money is spent in the acute sector. So one of the challenges for us, how do we have a transformation agenda, which is about working in partnership with the palliative care sector, with our hospitals, with primary care, with social care, with our community trusts, in the work that we're planning around collaboration. How do we have a model that shifts from acute, primary, and community? And we know that over the years, palliative care has changed. There are clear models and examples, and I'm sure some will be shared throughout the next few days, Sam, about good practice and what people are doing. You don't have to go to hospital. People can still have a good death at home with the necessary support and wraparound. So these are some of the things that we're working on initially as well. The final thing I want to say before the other panelists have their contribution is back to money again. We've worked out that we are, in terms of the formula that we receive our funding, so we commission healthcare for the population of Birmingham Solihull, we were actually underfunded, believe it or not. We don't get our fair share of money based on the demographics. We've got the youngest population in the UK, but we are now having a growing older population and people with complex long-term conditions, and we're a global majority city. And that does not reflect the money that we receive. So we have to work twice as hard compared to places like Somerset, Northumberland, Guildford, in terms of delivering some of the big challenges and targets that we've been told by the government. I'll stop there.
Fantastic introduction. Thank you, Patrick. And it sets out the kind of challenges from a commissioner perspective, which hopefully we'll also hear some more about how different providers are leaning into. But before I go on to Ed, just one question, Patrick. You talk about ICB as engaging with some of those big shifts already. How prepared for the future do you think ICBs are, based on your experience of talking to colleagues across across England? Is there a sense that they're well prepared for the future, or kind of fearful of the challenges ahead?
It's a bit of both, actually. I think, a number of the ICBs have really been working hard, like ourselves, around having a different approach around delivering healthcare. So we've had to move away from a competition models where providers were competing against each other for business, to a model whereby we have a system approach where we work collectively. Everyone signs up to the commissioning plans and intentions. That's one of the reasons why we've been able to have a financial balance for the last couple of years, because all the providers have worked collectively together. So we've done a really good start to the 10. The challenge that we are facing, which is across all the ICB systems, is and I know that the government allocates an extra £22 billion for the NHS compared to other government departments. So on one level, that's great. But as you know, the demand and the nature of the demand is rising. Just Christmas gone, between end of November, December, and early part of January, nearly all hospitals in the UK were on critical incident. All our hospitals in Birmingham and Solihull were critical incident, with double the number of patients come in for a whole variety of health conditions and issues, and we still have to do work with saying that there's a whole range of access. I mean, I know people go straight to A&E. So the work that we've got to do is, how do we shift the resources from hospital and secondary care to community? That's the model that we're working with. But to do that, we have to still do the day job around urgency, emergency flows, electives, whilst doing this transformation agenda. And that's the conundrum. We have to work within our financial resources, but we've got to do this transformation whilst delivering some of the big issues affecting hospital care and how we work with social care.
I think that's such an important challenge, Patrick, about how do we engage both with innovation, but in the context of continued pressures on and that focus on needing to deliver day to day, and balancing the two is going to be a big challenge for the future. Thank you so much, Patrick. Well, this sets us up, and particularly that question of pressures on hospitals sets us up really well to come on to Ed O'Brien from the Welsh Ambulance Service Trust, because I know, Ed, you've been doing some really interesting work in this space. Do you want to tell us a bit more about the work the Welsh Ambulance Service has been doing?
Oh, thanks, Sam. So Ed O'Brien, Welsh Ambulance. So, I mean, following on from what Professor Byrne and Dr. Sarah have already mentioned, in terms of system pressures, the biggest thing for us as an ambulance service is the volume of end-of-life care patients they're accessing 999. It is probably a bigger number than people expect. Sarah's mentioned about data collection being quite difficult in different nations, and the problem we've got is identifying end-of-life care patients that access ambulance services, because ambulance services are data rich, but we tend to collect everything but that tick box for end-of-life care. So we can identify symptoms, for example, but then you have to go through all those symptoms to identify, well, which one of those was an end-of-life care versus wasn't an end-of-life care. We've just done a very big data trawl. It's due to be published in the next couple of months, hence why it's not been included in the Nuffield Trust's data that you've just seen. And essentially what we did is we looked at 4 years worth of data. So within Wales, we're quite lucky that we're able to access data via something called Sale Data Bank. So all the hospitals, all the GP practices, the ambulance service, we all feed our data into one central point, and that's Sale Data Bank. And then you can pull back data from them and link it to things like the ONS death data, etc. And so we looked over 4 years, and what we found is actually on average 9% of our incidents each year, our treble 9 incidents each year, are to an end-of-life care patient, so a person within their last 12 months of life due to an advanced or terminal illness. And 9% is a really big number in terms of ambulance service. To give that context, major trauma is around about 2% of what we do in the ambulance service. So you can see that it's a big part of what we do. The difference being with major trauma patients is we're all set up for major trauma patients. Although it's only 2% of our work, we are well versed in what we do with those patients. There are clear patient pathways to follow for those major trauma patients. When we arrive at the emergency departments, there are clear instructions for them as to how they receive those patients. So they're offloaded quickly. They go into the emergency department. The difference being with end-of-life care patients is there isn't that clear pathway to follow, and often these patients are the ones that will be delayed on ambulances for many hours outside the emergency department. So lots of the end-of-life care patients that we are supporting haven't been identified as being end-of-life care prior to us meeting them on that treble 9 call. And going back to our data, statistically, we're most likely to meet a person in their last year of life, actually within their last 7 days. So at the point where they're accessing treble 9, they're likely in their last 7 days of life, according to the data that we've put together. So paramedics and ambulance clinicians are managing really difficult situations. These are points of crisis. And so I think a huge volume of those patients, so perhaps one that exemplifies the type of patient we're meeting is advanced frailty patients. So we are seeing, all different types of diseases and illnesses, but advanced frailty is a big part of what we do. I think potentially healthcare professionals may be more reluctant to identify a person with frailty as being approaching their end of life. Sometimes there isn't clear underlying pathology. I know there's a Marie Curie paper out there that suggests that practitioners have difficulty identifying when a frail older person has moved into their last period of life, and when they would benefit from a palliative approach compared to somebody who's got a clear terminal diagnosis, such as cancer, for example. So, our data has also recognized that on average, a third of all of our treble 9 incidents each year are to respond to a person who's age 80 years or over. Now, that's not me saying anyone age 80 years or over is, suffering from advanced frailty, but I had to pick a number to kind of say, well, how do I identify? And I think it's fair to say that going from 80 and above is more likely to be an advanced frailty patient than someone younger. So that's why I use that age. Many of these patients will be in care homes. And from my personal experience of responding to these patients, residents in care homes are often seen infrequently because of the pressures on primary care. They just don't have the capacity to do the regular home visits like they were able to do many years ago, because if they leave their practice to do that, who's seeing all the many patients who are then sitting within their waiting room? So I get why it's not happening. So deterioration and dying has often not been identified prior to the treble 9 call. And so these patients are often not on palliative care registers, and that does make a difference to us. So again, using our 4 years worth of data, only 22% of end-of-life care patients that we tracked back were actually on a palliative care register. And so the difference that makes to us is when an ambulance clinician is looking to support a patient in the community. So if an ambulance clinician recognizes a person who's likely in their last hours, days, weeks of life, and perhaps would not benefit from hospital admission, they'll link in with somebody like a doctor, so GP or GP out of hours. But if they're not on that palliative care register, if I'm linking in with a GP out of hours at 3 o'clock in the morning, and I speak to the doctor, and suggest a management plan, understandably that doctor's going to scan those medical records, and if there's nothing on those medical records to suggest that this person has been identified as approaching the end of life, the GP is more likely going to err on the side of caution and suggest, well, actually, I think admission is more appropriate. That's not saying that happens all the time, but that does happen. And so if you can't get additional support for that person in the community, you will end up admitting to the emergency department. I could go on for, I'm just conscious of time. I could tell you more about my data, but I'll probably pause at that point. And I think that's probably identified some of the issues that we face.
Thank you so much, Ed. It's a fantastic introduction to some of the challenges, and profound challenges they are indeed. And great to see the ambulance service in Wales engaging with this. I get one question here. It speaks to a question that came up in the has come up in the chat: is how different partners work together. This is a collective challenge, and clearly something which we perhaps don't talk about the role of ambulance services as much as we should within addressing the challenges of people at the end of life. But as you put so clearly, it's clearly a significant part of the work of any ambulance service. How do you work together with partners to address some of the challenges that you experience, and how important is that collaboration?
How have we addressed that with partners?
Yeah.
As an ambulance service?
Yeah.
So I could allude to the rotational palliative care paramedic model that we've had running for the last few years. So that's certainly helped. So that's recognition that ambulance clinicians need to get better at managing palliative care. So they need that additional knowledge, experience, and confidence in managing patients, within end-of-life care settings. And also there's recognition from specialist palliative care teams that they need to improve their response element. So go back 3 years ago, and Welsh Ambulance Service and Swansea Bay University Health Board Trust, their specialist palliative care team specifically, they were looking for how can we get better at adding that response arm to our service, while at the same time the ambulance service was looking at how can we get better at managing all the end-of-life care patients. So we came together and we put together a rotational palliative care paramedic model. And what that does is specialist palliative care teams are predominantly made up of doctors, nurses, and of course all the allied healthcare professionals such as OTs and dietitians and physiotherapists, etc. But they don't tend to have a response element. So the clinical nurse specialists, the CNSs, will manage patients day to day. They will do their advanced care planning. They will put things in place. They will do lots and lots of work. But despite all that amazing work they're doing, there will always be the patient that has that sudden and unexpected deterioration, and often those patients need a face-to-face. Is this a reversible cause? Is this the person who's dying? And in order to be able to do that face-to-face response, the CNS or the doctor would either have to cancel the person who they were meant to be going to see, or potentially persons because of the time it may take, or if they haven't got capacity, they would have to ask the GP or 999 to respond to that. So what we've done is we've got this rotational model where paramedics will work 50% of their working time in the specialist palliative care team setting, and they become their paramedics. So whilst they're in the specialist palliative care team setting, they're off the 999 radar. And for all those patients that need urgent face-to-face same-day assessments, and that might be urgently referrals coming in from GPs, or that might be patients already known to them that have suddenly deteriorated, their paramedics will go out and they will manage those patients, and they will link in with the CNS or the doctor. And what we're seeing from that is there's far less referrals from specialist palliative care teams, with paramedics now going into primary care and into 999. So we're reducing the burden on other services. But of course, the skills and knowledge that the paramedics are picking up there, they're now bringing back to their 999 setting. So when they're working in the WAST setting, in the Welsh Ambulance Service Trust setting, these are the paramedics that we are now sending where possible, because we have those paramedics on response cars, to our palliative and end-of-life care patients. And what we know from our data is, so over our 4-year data, we found that 58% of end-of-life care patients will remain in their own care setting when managed by a generalist ambulance clinician, if you like, versus 80% of patients who are managed by a palliative care paramedic remaining in their preferred place of care. So it's got mutual benefit to both sides, to both the specialist palliative care team and to the ambulance service, and of course the knock-on effect on the reduced ED admissions and the reduced GP referrals, etc.
Thank you so much, Ed. And what a great example of both work in the Welsh Ambulance Service, but working together with partners in order to address some of the system pressures in this space. We'll move on finally to Sarah Holmes. Sarah, do you want to share a bit of an introduction to yourself and your perspective on the system pressures facing palliative and end-of-life care, and a little bit perhaps about the REACT programme and the work that that's doing to engage with these challenges?
Yes, thank you. My name's Sarah Holmes. I'm Chief Medical Officer at Marie Curie, and I'm a consultant in palliative medicine at our hospice in Bradford. My pronouns are she and her. There's always a bit of a side effect of, well, a problem with going last, isn't it? Because everybody else has said the things that you were going to say. But lots of what Patrick, Ed and Sarah have said so far has really resonated. I think for me, in sort of pulling some of it together, one of the challenges I think we have in palliative care is, we have a system that currently isn't meeting the need of the population of palliative and end-of-life care as we have it at the moment, and that need is only going to grow. We have a disjointed system, I think, and I think one of the reasons for that is that, forgive me, but I think perhaps palliative care is seen as a nice to have and a sort of touchy-feely add-on. And I sometimes feel like we haven't been speaking the right language from a palliative and end-of-life care perspective. So thinking of the system pressures and everything that's going on and the demand to shift from hospital to community, etc. Patrick, you were talking about those targets that we have about reducing admissions, etc. I think we need to think differently about how we talk about palliative care actually fixing some of those problems, and working within the system to help address those problems. Thinking about our REACT model in Bradford, I think to Ed's point and to your point about collaboration, that's been an example of where we have collaborated across the system, looking at the difficulties we were facing, particularly in Bradford, with a population, a very diverse population from an ethnic, cultural, social perspective. And we knew that despite all our efforts, there were a proportion of that population that weren't being identified by anywhere in the system, by primary care, by GPs, by district nurses, by palliative care, by hospitals, as being in their last year of life. So those people were dying without the care and support that they needed. And we hypothesised that we'd spent a lot of time educating and saying, everybody needs to do things differently and everybody needs to do more advanced care planning and stop people going into hospital. We hypothesised that those people that weren't being identified were perhaps the people that were turning up and having those crisis admissions and spending the time in hospital. We knew that people in the last year of life in Bradford were spending, on average, 38 days in hospital, which I don't think is something that any of us would choose if we knew we were in our last year of life. So what we did is we collaborated with the Hospital Trust, with an organisation called Social Finance, who partnered with us and provided some funding. And we set up a model where we put some palliative care resource, specialist palliative care resource, into the emergency department, supported by a virtual ward model in the community, so that people turning up to the emergency department who perhaps hadn't been identified as being in their last year of life or having palliative care needs, there was a palliative care physician to work with the emergency department to identify those people, and where their preferences were to remain at home, to support them with our virtual ward model to discharge people home. And we've been able to show a reduction in those bed days in the last year of life. So patients are now, who are supported by REACT, the average number of bed days spent in that last year of life is 17 in hospital compared to that 38, so over a 50% drop. One of the really interesting things about it, I think, is that that drop happens regardless of whether you are discharged to the virtual ward model or you have to be admitted to hospital. So even if you do have to be admitted to hospital from the emergency department, the bed days drop to an average of 21 compared to 14 if you discharge to the virtual ward. And that is saving the hospital. So it's tricky, isn't it? Because it does save bed days, but those bed days are still, the beds are still full of people. But to Patrick's point, there is a chance that they're more full of people that are needing those elective operations or, etc., reducing waiting lists. And it's saving, for the investment that we've put in, it's saving the system money. So we've been able to talk in a different language about the value and impact of palliative care services.
Thank you so much, Sarah. And what a great example of innovation in practice that's working to address pressures on the whole system. Sarah, we've got a few comments in the chat about the importance of individualized end-of-life care plans and different people's priorities and preferences. Comment here from Sherry on this, and another from Hazel on similar topic. I'm wondering, you mentioned the importance of recognizing the different needs of different groups of people and different, like each of us treating each of us as individuals in the end, and the importance of that, of course, in addressing inequalities in care. When you're working across a whole system to address kind of whole system pressures, how can you ensure that there's the flexibility built into approaches to enable that focus on the individual's needs?
Yeah, that's a really good question. I think there's something in there. There's been a comment in earlier about public health approaches, and for me, there's something about co-design and understanding the needs of the population that you're serving, so that we're not delivering to, but delivering with the communities that we're serving. So understanding those needs and preferences. There's something as well about, I think, these advanced care planning conversations aren't one-stop conversations, so they don't have to all be done in one sitting. They are a conversation that evolves over time. So sometimes it's just about starting off that conversation or dropping the breadcrumb about that conversation and then following up on it. I think one of the things that we have learned with React is that we thought that advanced care planning conversations all needed to be done in sort of beautiful, calm, controlled environments with everybody around you. Actually, that's lovely, but you can have some elements of the conversation in urgent situations in order to just start that and to start to talk about preferences. So in the busy A&E department, we have been able to start those discussions about, actually, I want to be at home, and then you can follow up in a more controlled, calm way with the rest of the system working together in the home setting.
Fantastic, thank you. And seeing thumbs up appear before me in the air, but to the idea of collaborative service design. We talk about kind of planning individuals' preferences. Perhaps in end-of-life care, we don't talk enough also about involving people in service and system design approaches as well, which in the end perhaps is the only way to properly ensure that people's preferences were embedded in the support that's available. Fantastic, thank you, Sarah, and thank you to everyone for all of those introductory comments. I will go now to a few. We've had some questions being put in the chat, and I just want to go to a few of the questions. A first one, a question from Louise. System-wide change is difficult when funding sits within different areas. Spending more in one area may well improve patient care and be cost effective overall, but it's not easy in practice if that cost saving is found in another department or organisation. How do we simplify the system so that money can be reallocated from one area to another? I'm wondering, Patrick, working across an ICB, that must be a challenge you experience day to day. What are your reflections? Do you have any reflections on how you can get that kind of allocation of money to the right place when it kind of, that's often putting pressures on a different area of practice?
Yeah, it's an opportunity as well as a conundrum, and we've got some examples already that we've started to do that across, not so much in the area of palliative care, but the other areas around mental health, looking at maternity services. We're looking at issues around CAMS, where we've been able to, through the collaborative model and different ways, how our partners are working, we can do that. But I'd just like to say, in terms of the question around palliative care, we've started a dialogue with social, very similar to what Sarah talked about in Bradford. So we've started a dialogue working with social impact, yourselves, Macmillan, to because in our system, we, as Ed described eloquently about the challenges around emergency and the array of hospital ambulance services, find out last minute about people's conditions. We don't have an urgent response specialist team in our system. So what we want to do, working with all the partners, and plus with our hospitals and community trust, is to kind of create a 24/7 urgent response model, very similar to what Sarah alluded to in Bradford, whereby, and we've done some modelling work, and we believe that if we can develop this model, we could probably save and release 30 acute hospital bed days. If you look at the number of beds that we have in Birmingham and Solihull, it's a drop in the ocean, to be quite honest. And some of our hospitals have had to reduce their beds because of a significant challenge as well. So I think if we can get all the partners to work together within the NHS family, working with the palliative care world, working with primary care and social care, we could do that transformation agenda. It's hearts, minds, passions, and putting the needs of patients and their carers at the centre of that. So we're doing the modelling work with touch wood. I can't say too much. We hope that this could be signed off, and we can have a specialist team that could provide that response, that intelligence, that gathering, to make sure that people do have the type of death that which is appropriate, culturally sensitive, and reflective. Going back to Sarah Scobie's report, we are spending too much money in one end of the system, and it's not appropriate, and it's not right. It doesn't feel good, to be quite honest. I've been to our hospitals. I've seen, is it appropriate where you have a whole range of patients waiting to be seen by clinical staff, and we know in advance, or should know in advance, that this individual needs a special type of pathway, care and attention than being lumped into that kind of emergency crisis situation which all hospitals are dealing with. It's not right. It doesn't feel right in 21st century Britain that we're still doing this. So we have opportunity, and this is the role of the ICBs. We can knock heads together, work in partnership together, and work with the third sector in developing models which is appropriate and right.
What a great approach to innovation in practice. Again, Patrick, we're hearing no shortage of examples of practice. One question I'll come back to is kind of how do we scale them? How do we build up from them? We've heard, models being put in place in an ambulance service, but model of emergency department in reach. We heard up in Bradford. Now, Patrick, hearing about kind of opportunities around rapid response services. I mean, all fantastic models of practice and brilliant to see so many different innovations. I wonder whether one challenge for the future might be how do we learn from them and scale them up across the UK. But I'll come back to that question in a moment. But first, Sarah, Sarah Scobie, I wondered if you had any reflections from your work on this project or other projects about that challenge of how do you get funding to the right place at the right time when there are different pressures on different parts of a whole system?
Well, I think one of the things that's kind of important to recognise is that the balance of funding that we saw for end-of-life care is replicated in many ways for healthcare in general. So despite the intention for improving community care, actually it's acute funding that has gone up most in recent years. And So so I think understanding what some of the underlying drivers of that, I think the developing clear end of life pathways could well be a good solution in terms of identifying and clearly defining what that bundle of care needs are for people at the end of life, because at the moment those people are just not visible in the routine kind of services and the routine data. So I think the idea of identifying clear pathways and embedding them in the development of emergency care planning of different areas of care planning is potentially a route for ICBs to structure their thinking, or other commissioning population-based groups to structure their thinking around the capacity that they need, where they've got gaps in their system, and how those could be addressed. Because at the moment, I think where the money's going just isn't clear to people, and I think making that clear and then using that to start the discussion about, are we spending this in the right way in our area, and what difference would it make, and how would we monitor it, how would we evaluate the impact, is some of the conversations that need to be happening everywhere.
Thanks, Sarah. I think that's a really important point about thinking about the whole pathway for a patient, and in that way thinking about the different services, different parts of the system that need to be involved. Maybe I can go back to this question of scaling up innovations which are starting to kind of prove their effectiveness. And Ed, I'm curious, from Welsh Ambulance Service perspective, do you have conversations with other ambulance services about kind of learning from the work you're doing in Wales about the implications for care in other parts of the UK? Do you see kind of routes to kind of getting kind of where there are proven effective models of practice, for getting them kind of scaled up and implemented in other places as well?
Yeah, absolutely. So we've got a national group. It sits under so AACE is the Association of Ambulance Service Chief Executives, and they have a number of groups, one of which is the End of Life Care Leads Group, and that's chaired by Jen Scott Green, who's going to be on one of the presentations in a couple of days' time, I believe. And what we do as ambulance services is we meet bi-monthly and we just share what we're doing. Has it worked? Hasn't it worked? And it's a case of, take my ideas and let me take your ideas. And we found that to be massively useful, because, you can learn from other services, but there isn't going to be a one size fits all, because every area and every service has got their own little, slight variations to how they may or may not be able to do things. But there's some ambulance services are more geared up to managing end-of-life care patients than others are currently, but we know that's shifting, and that's only shifting because we're meeting and we're sharing information. And of course, there's people like Marie Curie and other third sector organizations who are now coming in and saying, let us help you grow these ideas, because often money is the barrier to change. And so with third sector coming in and offering to support us with these ideas, it's making a massive difference.
Thanks, Ed. And I'm a big fan of Jen Scott Green, as you know, and the work that she's done leading that group is fantastic. And you did in the past yourself, Ed, of course. But
yeah, we share the chair every few years. It goes to another person within the ambulance service, and Jen's doing an absolutely fantastic job at the moment.
And I think without kind of bringing this back too much to the charity sector, I do wonder whether that is kind of an important role, actually, of the charity sector, that we can, in a way that statutory organisations perhaps have that kind of less of a kind of less of that kind of public voice and that role in sharing conversations in the press, in Parliament, in all of those different places. That's something that actually charities can do really well. So working with statutory bodies in order to share examples of good practice and say, look, we know something works well. Let's all collaborate. Let's think about how can we make sure that we're getting this scaled up, we're getting this introduced in different places. That's something I think that organisations, like Marie Curie, but others in the charity sector can really help with. So, and really, obviously, keen to do, because that's a key part of our charitable purpose and what we're there to do as an organisation. Thank you, Ed. A couple of further questions coming in. I had a great question here from Z from Singapore. Thank you for sharing your thoughts and experiences. It's very eye-opening. Thank you, Z. It seems like there is a big pull to demonstrate the value of palliative care to convince funders of its value. Curious of the way forward for economic evaluation of palliative and hospice care, given it's not easy to measure the impact of palliative care in dollars and cents. Or indeed in pounds sterling in the UK. It's great to have an international audience. Sarah Scobie, maybe I can come back to you on that question. We know that there are some economic evaluations. We did one, Marie Curie did one with York Health Economics Consulting a couple of years ago, did one actually with Nuffield Trust 8 or 9 years ago. What are the kind of challenges and opportunities around economic evaluations of palliative care?
Well, I mean, I think many of the data challenges that I've already mentioned are very relevant. But that having been said, there has been quite a bit of work looking at how you measure outcomes in end-of-life care, and different tools developed that capture patient and family-centered quality of life measures. So traditional economic evaluations would look at quality of life, QALYs, how much longer you live and how your quality of life is improved by and an intervention. And clearly that doesn't really make sense in an end-of-life care setting. But there are other outcome measures you could use, so they could be specific to clinical things like pain control. They could be outcome measures in terms of things you want to prevent. So emergency admissions might be one, and then there are also measures that take different approaches to developing quality of life. I think one of the things that we didn't cover in our costing is expenditure by families and individuals, and how you quantify carer costs. So I think that would be a really important thing to consider if you're evaluating services. So I know there's been mention about virtual wards, but if I was thinking about evaluation of a virtual ward, I would really want to understand what the implications were for the family, because I think that you need to take that into account, and also think about the inequalities aspect and what it might mean for people with different family resources and different household resources.
Such an important point. The point about informal or unpaid carers often gets neglected in discussions about provision of care and support, and something which we know can. The whole system wouldn't work without unpaid carers, right? And providing billions of pounds of additional value and service support for people, and we've got to get the care right for care right for carers as well, to enable both to enable that work and ensure that they're not taking on more than they can manage themselves. So thank you for kind of bringing that part of the discussion in as well. And it fits quite closely with actually another question that we had a little bit earlier, and I wonder if I can bring Sarah Holmes in on this one. It's from Catriona, and a question about whether GP collective action and chronically understaffed and underfunded community teams can cause issues with shifting care to community settings. How much of a challenge do you think that is, Sarah, particularly when introducing system interventions like your REACT work? You're finding challenges with getting the community care access, can be including through primary care, and potentially also pressures on unpaid carers as well, can make it more challenging to introduce effective new interventions.
Yeah, I think that speaks to the point of being important that whatever you're looking at in terms of innovation is truly co-designed across the whole system. So one of the things we did with REACT was ensure that GPs and district nurses and primary care teams were very heavily involved in designing the service. One of the big concerns at the start was that we were going to be identifying a whole load of extra work for people, so sort of opening the floodgates for professionals that then they wouldn't be able to handle. I think in reality it hasn't turned out to be that. The service has helped support people through a crisis and then has been able to hand on those people in a calm and planned way with a plan in place for the future management of them. So that has been okay. I think the point about carer burden is really important though, and I think there is some work that the British Red Cross have done about inequities in virtual wards and how we ensure that we aren't driving further inequity. So I think there's a challenge for us to think about how we make sure that we don't do that, and we support people to be able to have their care at home when they want it, and that is a challenge. There's a great book that I was just about to put in the chat called Labours of Love by Madeline Bunting, I think, if people haven't already read it, that talks about some of that caring burden and does include some economic stuff about that.
That's fantastic. Thank you, Sarah, and an excellent book. I think that it does raise this question of this shift from whether through virtual wards or more care delivered in other ways. The shift to providing care to people at home does raise new challenges and does bring us back, including Sarah Scobie, your point about right at the start about the challenges around social care provision. I think it brings some of those challenges into sharper relief. We know from Marie Curie's own work, more than 100,000 people each year die in poverty, face poverty at the end of life. And for those who are being cared for at home, those challenges particularly profound. If they're not able to turn the heating on, or they're not able to power medical equipment, it makes it so much harder to make sure that care and support can be appropriate to their needs. So thinking about that incredibly important. Ed, you put a comment on the chat about advanced care planning. I'm curious about your reflections on it, on ensuring we're thinking about patients' own preferences at the end of life and some of the challenges in doing so as well. Did you want to come in at all further on that comment?
Yeah, I can do. I can see it's got a couple of thumbs up, so it seems to have other people are agreeing with that. So that's awesome. So there's been lots of mention of advanced care planning, and we're all aware that the process of advanced care planning is that ongoing conversation. It should be something that is continually done, as and when appropriate. But the actual ACP, the advanced care plan, and I'm speaking for me as a paramedic, so you know, others may have other opinions, but for me, an advanced care plan should be that. It should be a plan, and often it's not a plan. Often it's a collection of thoughts that the patient may have shared, and that's really important to the patient, but it's unlikely to help us as a paramedic at 3 o'clock in the morning when we're being asked to respond to a patient. And the information we often get for these patients is so limited. You know, so I might be going to a treble 9 call where it just says difficulty in breathing, and that's all I know about that patient. I have no other knowledge on that patient, so I don't know, is it a chest infection, is it an asthma attack, is it, you know, end stage lung cancer, until I get there. So I'm reliant on information gathering when I get there. And the ACP is going to be really useful for me if it does include that information. So list what's, you know, what is that person's illness, you know, if possible, even, you know, list where that patient potentially is within their disease trajectory, you know, and if we're saying hospital's not appropriate, why is it not appropriate? So just listing the things like, you know, they have come to the end of the treatment, there is no more treatments to offer, is really useful for us to know as a paramedics. It's often an advanced care plan will just have something as simple as would prefer to avoid hospital if possible. And that always makes me smile, because I think that's everybody in the world. None of us want to go to hospital. So documenting that line means nothing. And so I'm just going to encourage people to think of the end user. So the paramedic is often the end user, because if the person's still got capacity, we'll ask that person. We only need that ACP once they've lost capacity. And so what is it that you would want the paramedic to know that will help us to keep that person out of hospital? I.e., if you're expecting to see certain symptoms as they approach the end of life, put that down for us. If there's a specific medication that's useful for that for that patient that's managed those symptoms in the past, document that as well for us, because that's really helpful. But the most important thing for us is having a phone number. So, you know, in and out of hours. So in hours is great, but out of hours is probably where we're going to meet this patient. So who can we ring at 3 o'clock in the morning to speak to somebody who says, thank you for ringing me. Yes, I know that patient. How can I help you? And then we can discuss why we've been called, and potential management plans can be put together, because otherwise the default position for a paramedic who is unsure is likely to be admission to hospital. And that's not going to be potentially the best outcome for that patient. But if we don't have the information to support us keeping that patient away from hospital, we don't know if it's appropriate. And so we will default to admission. So the more you can put in the ACP for the end user from a clinical perspective, and I know there's people out there who would argue ACP shouldn't be clinical. I guess that's a different argument, but don't hang your hat on the ACP keeping the person out of hospital unless you're giving the end user the information they need.
Thank you, Ed. That's such an important point. And again, speaks to the need to think about the whole system when making change to kind of one part of it. Thank you so much. We're coming to the end of the session now, and what a fantastic discussion it has been. But I can't end without asking the question. You cannot go into a meeting with Department of Health and Social Care in England at the moment without them asking, how would you like palliative care to look in 10 years' time? Because they're working on a 10-year plan. So I'm going to ask the same question to our panel to conclude. What one change would you like to see that would improve palliative care in 10 years' time? What would you like to be different in 10 years that we're not there with yet today? Sarah Scobie, can I start with you? Based on your work and the data you've seen, what change would you like to see introduced in the next 10 years, which you think will make a difference to palliative care?
So I'd like to see the place of end-of-life care being much more prominent in health policy thinking and in all the things that support that. So the data collection and seeing the people who are at the end of life being much more central to thinking about what a good health service looks like, and considering the needs of people at the end of life much more centrally, because at the moment I think they don't come through in the things that are at the top of the list for well, certainly for politicians and therefore for many health leaders.
Thanks, Sarah. It certainly doesn't feel like that, but a challenge for us all to make sure we get there. Thank you, Sarah. Ed, over to you. What would you like to see that's different in 10 years' time?
Oh, wow. Okay. So many answers, but you only want one, but I'm going to give you a few. So I guess the ideal would be people aren't called in treble 9 anymore. That's the ideal. So, whilst we as an ambulance service want to get better, we absolutely want to get better at managing these patients. The dream is that patients don't have to rely on treble 9. So more investment and more resources put upstream into places like specialist palliative care and generalist palliative care within primary care, so that patients don't have to resort to treble 9, because the treble 9 option is never going to be the best option. We're trying our best at it, but we're not the right option. So yeah, that's I guess that's the dream, is patients don't need to come into treble 9 anymore.
Thanks, Ed. And Sarah Holmes, same question to you.
Oh gosh, I hate picking my favourite record, let alone trying to narrow down the single change. I would like to see palliative care as considered as a mainstream specialty, so truly integrated into health and social care. And I think in order to do that, and this is a really massive thing that can't be achieved by the NHS plan or policy, we need a cultural and societal shift in how we view end-of-life care and dying, and that needs to happen across the whole of society, but also, because we're part of society, across medical, health and social care. As professionals, we form part of that society, and that contributes to how palliative and end-of-life care is viewed.
Thanks, Sarah. A real cultural shift needed. And Patrick, from your perspective, what would you like to see different in palliative care in 10 years' time?
I think there's two things. As you know, I was involved in the Bereavement Commission, which was looking, and it's really about the conversation of how we talk about death and dying as a nation. Until we have those proper conversations, then palliative care will always be seen as a Cinderella industry, and it's not. It's actually far more deep than that. It's about our life course. So as we talk a lot about the same conversation, we talk about young people, and we should be talking about death and dying in that same way, which then means that you have to fund it properly. So we need to have that conversation, and then it needs to be embedded in health systems. So ideal scenario for ICBs or any future kinds of commissioning models in the future, who knows what's going to happen, is there is a proper funding allocation that ICBs have, instead of us looking at steal Peter from Paul to make and cobble something together. A proper funded system for palliative care is required, and I think I'm hoping the Commission on Palliative Care and End-of-Life Care, I'm sure that's going to be one of their recommendations when their report comes out later on this year.
What an important message to conclude with. Thank you, Patrick. So we need cultural change around palliative care, better conversations about death and dying. We need a properly funded system. We need it central to our health and social care discussions. And we need, as a result, less people ending up having to call 999 because they're already getting the care and support that they need without having to call for an emergency service. Well, I think that's a vision it feels like we can all get on board with. So thank you so much. Thank you so much, Sarah Scobie, Patrick Vernon, Ed O'Brien and Sarah Holmes for joining us. This morning. It's been such a fantastic conversation. I'm really looking forward to seeing how we can continue that in over the course of this conference, over the coming week, but also going ahead over the coming decade. So thank you all. I'm seeing lots of applause. I feel like I want to have a real round of applause, but it doesn't really work on video call. So I'll just say thank you once again and admire the clapping hands. So we're going to now move, I think, just to keep to time, there was a break schedule, but I think we will press on. and have, for the final session now, announce our 4 conference award winners, because each year we of course have our conference awards, and this year we were delighted to present them as part of this opening session. So first of all, each year we present the winner of our prestigious Susie Wilkinson Award, which is the internal only award at Marie Curie. We're immensely grateful to Susie for enabling us to award this long-standing prize each year. The award was founded in recognition of Susie's significant contribution to palliative care research and Marie Curie in establishing the unit at the Royal Free in 1999. The award was established on Susie's retirement in 2005 from her post as head of the Marie Curie Palliative Care Research Unit at UCL. This award aims to recognise and support a member of Marie Curie staff or team who has made significant progress in building their research skills. This could be through conducting their own research or by using research and evidence from others to guide their work. Those eligible to be nominated are health and social care staff, for example, healthcare assistants, allied health professionals, doctors, nurses, social workers, and pharmacists. The winner is awarded up to £1,000 to spend on professional development to further build upon their research interests and skills. Now, we received fantastic nominations this year, and it is really great to see so many staff across the charity showing interest in developing their research skills or using evidence in their work when caring for patients. And it's my pleasure to announce that the 2025 winner is Colette Parfitt, who is a physiotherapist at the Marie Curie Liverpool Hospice. Colette leads a local falls group at the hospice who work to reduce the number of falls in the hospice setting. She evaluated and identified the need for a more tailored approach, leading to the development and implementation of the Falls Early Warning Score Chart at the Liverpool Hospice. Recognising the importance of evaluating staff confidence and the impact Fuse assessment tool, she collaborated with the research team to secure a Marie Curie small grant in 2023, developing her research skills while continuing her full-time clinical role as a physiotherapist. Colette aims to use her research findings to refine the tool and develop an educational package for staff implementation across Marie Curie and potentially expand its use into other palliative care settings. Colette plans to use her prize money to attend an international conference to disseminate her work further. A huge congratulations to you, Colette. Really fantastic stuff, and so great to see research positively impacting care for our patients at Marie Curie. Well done, Colette. Our next 2 awards were open nomination for any project related to death, dying and bereavement. They did not have to be funded by Marie Curie to enter. If you're interested in making a nomination for next year's round of awards for the following, these open when registration to the next Marie Curie conference opens and close in early December. So do keep an eye out on our website and research newsletters if you're interested in making a future nomination. Each award includes a monetary prize, providing valuable support to extend project work, enhance dissemination, and/or foster professional development. We encourage you to consider making a nomination in the future, whether for yourself, a colleague, or someone whose work you admire. It's so great to have the opportunity to kind of share some amazing examples of practice and some outstanding achievements through making these awards. So, firstly, Marie Curie's Research Impact Award is named after Claire Fisher, who sadly died in January 2022, having lived with a terminal illness since 2018. Claire was a passionate and influential advocate for improving well-being in palliative care. After retiring from her job, Claire started the impactful Dying Well project. It's an amazing project, it really was, in collaboration with the What Works Centre for Wellbeing, where she documented her personal journey and explored the evidence around wellbeing in terminal illness. The project brought people together to share their learning and identify where the evidence gaps were when it comes to living with a terminal illness and wellbeing. Many listeners today will undoubtedly have heard of Claire following her blog, read her tweets, listened to her podcast, or heard her on the radio. And we're very grateful to Claire's husband, John, and her family for giving us permission to name the Research Impact Award after her. This award is aimed at celebrating and highlighting examples of palliative and end-of-life care research that have had notable impact on policy and/or practice. The award is open to nomination from anyone who feels their research or someone else's research has had a meaningful impact. The winner receives up to £1,000 to spend on further impact work or professional development. It brings me great pleasure to announce the winner of this award is Dr. Michelle Mile, Principal Research Fellow at the University of Southampton, who has won the award for her project, Domestic Abuse and Life-Limiting Illness, Identifying and Supporting Adults at Risk. Their research led to the development of the DALI Toolkit, which includes resources to support health and social care professionals working with people with a life-limiting illness to inquire and respond to domestic abuse encountered in practice. The toolkit has been implemented in 15 hospices to date in England and Northern Ireland and generated interest from as far and wide, including Australia and the USA. It's also been adapted by local authorities, various NHS trusts, and also Marie Curie. The panel of experts across research, policy, and practice praised the innovative approaches of the project, as well as for how important and wide-ranging its impact has been and will be in the future for people at the end of life and their families. If you'd like to read more about the project, a video link will be posted in the chat very shortly. The panel also selected the following project as their runner-up: Compassionate School Communities, a 3-year programme of work undertaken by Marie Curie to promote a compassionate school culture in Northern Ireland, strengthening school-based loss and bereavement information and support for pupils. If you'd like to hear more about that project, they're doing a spotlight presentation at the conference later today at 12:30. Well, huge congratulations, Dr. Michelle Mile, and to everyone involved in the Compassionate School Communities project. It is so inspiring to see how research can make a meaningful difference in supporting those affected by death, dying, and bereavement. Huge congratulations, everyone. Our next award is the Tammy Prescott Patient and Public Involvement Award, which is in memory of Tammy, who died in May 2023. Tammy made major contributions to Marie Curie's Dying in Poverty campaign. She, for instance, delivered a petition with over 166,000 signatures to Downing Street and met with Sir Keir Starmer, calling for improved financial support for people with terminal illness. Despite undergoing intensive treatment at the time, she continued to use her voice to provide lived experience insights to drive forward engagement with the campaign from both the public and politicians. Marie Curie is immensely grateful to Tammy and to her family for all of their involvement and support throughout the Dying in Poverty campaign. Broadcaster and Marie Curie ambassador Chris Kamara, MBE, got in touch to say it was an honour working with Tammy on the Dying in Poverty campaign. Tammy was an extraordinary woman who I was privileged to have met. Her profound contributions really drove forward the engagement from both public and politicians with the campaign. He added that this award highlights the important difference and impact that involving people with lived experience can have on research and policy work. Now, last year, we were honoured to be joined by Tammy's partner, Linton, for the first awarding of this annual award, where he told us how much the award means to him and to his family. This prize is aimed at recognising, supporting and rewarding meaningful involvement of people with lived experience in research or policy work. This involvement is often referred to as patient and public involvement and refers to projects being carried out with or by people with lived experience rather than to, about or for them. For example, having people with lived experience co-lead a project or sitting on the steering committee to guide decision making. This helps ensure work and findings are accessible, relevant, and in the end, truly beneficial to those affected. The winner receives up to £1,000 to spend on further PPI work or personal development. The award judging panel, made up of individuals with lived experience from our Marie Curie's Research Voices group, were delighted with the high quality of the nominations received for this prize this year. And it is my pleasure to announce the Victoria and Stuart project as the winner. The nominees covered a multi-centre research team and all the people with a learning disability, families, support workers and professionals who were members of the co-design. The NIHR funded project focused on co-designing a toolkit and resources for end-of-life care planning with people with learning disabilities within social care settings. The panel selected this project as the winner of the Tammy Prescott Prize as they felt that the team demonstrated a very strong commitment to patient and public involvement and co-production throughout the research. People with learning disabilities were involved throughout the project, from introducing the research, being part of the project advisory group, co-designing the resulting toolkits, and disseminating the work. 2 of the researchers in the team themselves had learning disabilities. Overall, the panel felt that the involvement of people was at the heart of this research, and their meaningful impact shows in the toolkits, which are publicly available and clearly demonstrate the involvement of people with learning disabilities. If you'd like to hear more about the project, and it's a fantastic project, really recommend finding out more about it. A link will be shared in the chat shortly. The panel voted for Jodie Crooks from Marie Curie and Gareth Davis from Pathway with his lived experience for their work together on exploring the idea of deaf cafes for people experiencing homelessness and awareness raising around the complexities and considerations for deaf cafes within this population. So congratulations also to them as runners up for the Tammy Prescott Award. Congratulations, huge congratulations again to everyone who was involved in the Victoria and Stuart project, and of course to Jodie and Gareth as well. So our final annual conference award is the prestigious Joanna Mugridge Award. This award is in memory of Joanna, who sadly died in May 2000. Joanna worked as a nurse at the Marie Curie Hospice in Caterham, and her family kindly created this award in her honour. Marie Curie is very grateful to Viv, Emma and all of Joanna's family for their continued support for the prize and for research in general. It's an honour that Joanna is celebrated every year in this way at Marie Curie, ensuring her interests and memory live on. Each year, we have multiple posters submitted to our conference relevant to all the themes discussed over the full conference week. This year, we received 37 fantastic posters, which you can look at on our conference platform by clicking on the Explore button on the top left corner, then clicking on Posters. There's a fantastic selection there, and a lot of poster authors recorded videos of themselves talking about their work. Each poster booth has an area where you can ask the poster author a question if you want to know more or to network with them. Please do consider submitting an abstract poster to our conference in the future. All successful abstracts will get published in the BMJ, and all posters automatically enter into this prize, with first place receiving £500 and runners-up receiving £250 to go towards their professional development. So the judging panel awarded 3 prizes this year. First place goes to Alison Rodriguez from the University of Leeds and the Dignispace team for their poster called Co-Designing a Digital Meaning Making and Legacy Leaving Intervention for Young People with Life-Limiting Conditions. Alison will also be presenting on her work at our selected abstract presentation session on children, young people and families, starting at 3:30 p.m. this Friday. And the selected runners-up were Dr. Bhumi Mehta and Dr. Julia Bishard from Watford General Hospital with their quality improvement project poster called Embedding Clinical Frailty Scoring and Advanced Care Planning on a General Medical Ward. The final runner-up was Rehan Hussain, a second-year medical student at King's College London, and his team with poster called Supporting Employees with Terminal Illness, a review of policies from research-intensive universities in the UK. So, huge congratulations to all the poster winners, and thank you to all other poster authors too. Please do go look at the winning posters and our other conference posters, which are all on the platform. So congratulations to all of our award winners and runners-up. It really is truly inspiring to celebrate the outstanding work being done in palliative and end-of-life care. And thank you also to everyone in the audience for joining the conversation today and sharing your own experiences, reflections, comments as well. It's been such a fascinating and engaging conversation this morning. I'm looking forward to the session through the course of the rest of the week. So we hope this session has given you a flavour of what to expect over the 4 days of our conference. And we very much look forward to seeing you at our next session today on strengthening grief education and bereavement support in educational settings, which starts at 12:30. And remember, if you're unable to join the session live, recordings will be available on this platform not long after the session finishes. So you can catch up when you're going for a run or whatever, whenever you listen to a podcast. Listen to Marie Curie conference sessions. It's a great way to get the brain cells going. So they'll be available after the session finishes, so you can catch up at any time that suits you. And please do check out our conference booths and the 37 brilliant posters that we have available. Which leaves me just to say thank you so much. Thank you so much again to all of our speakers this morning. Thank you to congratulations to all of our award winners, and thank you also to everyone for listening. And enjoy the rest of the conference. Have a wonderful day, and goodbye for now. Goodbye.